Hi, Maulik.
Hi, Dr.
I
Maulik.
want the
We're
light
live.
on.
Yeah.
I want the
Hi.
light on.
Hi,
Hi,
sir.
Dr. Goel. It's nice to see you.
Who's on the chair?
They can't
Yeah.
hear us.
Ravin, are we in
He's Dr.
UP or you're in Mumbai?
So who's on the chair?
Hi,
I'm in Mumbai,
he's
man.
a phone- she's sitting next to me, and then Peter and Andrea kind
So-
of find out.
So we have Dr.
Hi,
Amar
Peter. Hi,
Peter,
Giza.
Dr. Geza Fontes,
Okay.
Dr. Binoy John chairing, and
So the,
Dr. Hajra, Dr. Kane, Dr. Sathe, and Shodatta and Ajit Bhagwat as panelists. So we have a big panel and we want to
Okay,
see your
sir.
case.
Great.
Can you tell us about the case?
So, yeah. Actually, this is a case which is, I think Dr. Maulik will describe the history. Will you want to describe
Yeah,
this?
okay. So it's a
So-
54-year male, hypertensive, ex-tobacco chewer, has chronic stable angina, functional class 2 since last 6 years, had an angiography in 2016, but details are not available. He was managed medically then. Now, since last 1 month, he has worsening angina, ECG is sinus rhythm with inferior Q waves.
Light.
Echo has RWM in basal and mid-inferior infiltrator wall, EF 45, but good preserved thickness. Angiography, RCS, CTO, LED proximal around borderline 60% lesion, LCX also proximal around 60% lesion, and is on optimal medical management. Next slide. Investigation-wise, it's unremarkable. And now we come to the fluoro screen, please.
Yeah.
So we
if
show you the,
angio. So now if you see the angio, you are seeing a still frame. Can you see a still frame here?
We are
What they
seeing
can see will be
3-4
seen here.
frames.
Okay, what is here?
yeah.
Okay. Okay.
Yeah, now we are seeing it.
So we have access from the left groin, from the right groin and the right radial. So usually I like the right radial to do the main work and the groin to do the support contralateral. That's what we started with. So we have the Judkins in the left, and the left is showing filling of the right through collaterals. The right is totally occluded with there is a branch, RV branch at that point. And if you see the run, you see the RO view also, the next one. So the collaterals, as you see, these are all surface collaterals, epicardial. The septals are not giving the collaterals. Largely the RCA is filling through RV branches, which are filling from vessels from the LAD, which are very tortuous. So these surface collaterals may not be good collaterals as such for the RCA. So I think the approach here, what I would think of would be primarily antegrade, because we don't have septal collaterals, okay? So can we see the next angio, please? So, but this guide that we usually use is a SAL. So unfortunately the SAL was not available and this was not giving good stability, so we had to interchange. So can you show now? So now where we are, next please. Okay, where are we now?
Yeah.
We'll see an injection now. Right injection please. Left injection please. Okay. So that is where I am. I have changed the guides. I now have from the groin, I am accessing the culprit vessel. And that is a JR 7 French. Usually like to do with a 7 French catheter. And for contralateral injection, I have a diagnostic catheter on the left.
You have a microcatheter already in the
And
lesion.
with a regular wire and microcatheter, yes. With a regular wire Sion and a microcatheter, I reach the lesion mouth, and that is where I am. And so
if you can
at
see
this
the
point, I
if
have
you can see the ipsilateral artery by same injection RCA, why you need a retrograde injection? You can see the whole RCA distally.
No, we are not seeing by the same injection. The entire thing we are seeing by the left injection. You see,
Okay, sir. Okay.
I have injected simultaneous.
Okay.
Simultaneous
And you
injection.
cannot do with only one injection, because when you will do, you will occlude. You see, right now there was some flow antegrade if you saw in the original injection through bridging collaterals, and now that my microcatheter is inside that channel, So those collaterals are also gone, bridging collaterals.
So which is the
So
wire you're going to
this
use
is
now?
time, huh?
Your choice of wire in such a situation? Because there
So
seems to be some.
I think usually now what I do is, my choice usually first is a Fielder XT. That tells me, by that I will explore the lesion as to how tough it is. Because history dates back to 6 years, and he's been having definite angina for such a long time, which might have worsened of late. He had an angiogram also 3 years back, so the details of which are not available. So I think this is a chronic occlusion. You do have some microchannels sometimes, and chronic occlusions like this can also be crossed. So, but in this case, well, I will keep my strategy anti-grade because I don't find good septal collaterals, and I don't want to do through those RV branch collaterals. And if I do not succeed, then this may be a good case for Stingray, because the distal vessel is good size RCA, and in case I get subintimal, I will change my strategy, and that was the hybrid approach that I always do. I will change my strategy and immediately get on to a Stingray without crossboss.
Absolutely.
So let us
I
see
agree.
how it
I
goes.
think that
And
should be the
it will-
strategy. Yeah.
So he's first going for
So
wire
someone can show my hand what I am doing. So right now this is XT, and what I do is only rotate. And right now I'll be able to see only through the left injection, not through the right. And I will ask you when to inject. The wire is not really moving much, maybe a little, because I am not pushing the wire. That is very crucial. You just rotate, because this is a 0.9-inch, 0.8 gram low tip load, and there is a polymer jacket, so it will slide down. I find it good. So let me see where I am right now. Left injection, please. So there you see I am, so that is the distal end of the occlusion. So I am inside the occlusion, but still I have some more work to do.
Angles, so that at least 2 angles, that's the standard teaching. So
Yeah, I know. I usually work biplane, but here it is single plane. Most of the people work single plane. Can we have a RAO view also, please? Can we make it RAO, please? Left injection, please. Yeah, looks okay. You see, the RCA is going inside at that point. My wire is also heading inside.
Looks good.
So looks okay.
Come back to LAO.
This would be the right time. If I don't move forward, then I will accelerate the wire. But I think it should be okay. Let me just go on, because
See, one of the things
if
that
you want to
I-
see
I
my
would-
hand, how it's rotating, you can focus on my hand.
Time.
Dr.
Goel,
Kane, would you
Goel,
start
you
with the-
continue, but Hazra,
that's,
I just wanted to discuss. If you see the RCA, tip of the RCA catheter is looking the other way around. So just a
LAO,
slight
please.
clockwise look
Clockwise rotation.
can give you a good support in such cases.
Would you
So-
start with the Gaia here
Pardon?
instead of Fielder? Would you start with the Gaia 2 or Gaia 1?
No, I think this wire will
This
cross.
wire is
That's what
moving,
I
so
believe.
it's, I
I think he's almost there. So otherwise you can
Short
obviously.
segment,
Yeah. There seems to be some faint channel, maybe, but he's the better person to know it. So I suppose if this doesn't work, he'll go for a Gaia. Is that right, PK? If you the next choice of the wire.
Yeah, you're absolutely right.
Yeah, would be. Yeah,
Because I am not wanting to push this wire.
absolutely.
I'll just move my guiding a little, the micro a little forward, and see if I can move a little more, because otherwise it gets subintimal very fast, you see. Can you just help me move it a little here? Unlock it, move it a little closer. Thank you.
They have half an hour. They have spent half an hour. Okay, we'll just.
Because that case is interesting.
Yeah. This is also interesting.
I think I have gone somewhere. Did you see that?
Yeah.
You can store the fluoro.
Maybe some RV branch or something.
Oh, if it's RV branch, it's fantastic, because that means I am in.
Yeah.
Is it?
So we need again the left injection.
Left
please.
injection, yeah.
We again
The
need
basic
the left
concept is
injection.
never inject in the RCA
Left
in such a
injection,
situation,
please.
Yeah.
Yeah, I think I am in. You see that?
I think, yeah.
RAO view, please. Now you see. Now I need the RAO view, please, because what looks here inside could be somewhere
Outside,
else
yeah,
outside.
absolutely.
So we have to
That's
be very
why-
careful on this
Yeah, that's
accord,
why
you know.
always two orthogonal
And
views.
you know,
Yeah.
so where is the damn thing? Yeah.
So where are you in the section?
Very
Subintimal?
slimy.
We'll go there.
And your left injection, please. Yeah,
Yeah, we are okay.
I think probably we are in on both the planes, so we are probably okay. So back to LAO, please.
Is the wire movement free? How do you make out? Goel, because there are people with different levels of experience here. So how do you make
Yeah,
out
wire
whether you are
that is
subintimal or whether
something-
you are in the lumen? How do you make that out?
That is, I am through.
Pardon?
You see, that is my feel. That is my feel.
No, I
It's
understand,
very
but
difficult to transmit it to.
you have to
but
express
I
your
can tell
feel
you,
to us so that
I
we
can tell
also
you what
understand.
happens is, I'll tell you. No, I'll express it. The thing is, when I am moving the wire, whatever movement I am doing at my tip here is happening there.
Absolutely,
And
yeah.
if I see that whatever I am doing here is not happening there, that means it is stuck somewhere. And if
Absolutely,
it is
yeah.
stuck somewhere, it is incorrect. You
That's
get
correct.
it?
Yeah.
So that is the thing, and rest is the feel. And you see, so now this is 6 years old CTO,
Yeah.
and I have crossed it with a XT.
Yeah.
So this is this is what I teach and preach.
That is your skill.
Oh,
I
That is
think
your
it's a good
skill,
strategy to
doctor.
start with
Yeah, it's a fantastic
XT.
strategy.
Yeah.
That's my, I don't know what it is, but that's what it is.
I think that's why it's good to start with such wires and not directly start with a stiffer wire. We can always escalate it at a later stage.
And now what happens, this is a very flimsy wire, you know. Even to proceed further, I have to still rotate it and move. I can't sort of just push it. And maybe I'll have my micro catheter move forward if it is possible.
The guide is
I'm
coming
trying
out.
to-
So.
Yeah, check an angiogram.
Guide, guide, please, guide. Yes.
How many of you think that the wire is in the true lumen now?
No, wire is in the true lumen. I think so.
It's
yeah.
in the
It's moving well,
it's
it's
in
turning
wire is in
well.
the true
So
lumen.
you have enough indicators to say that it's in the true lumen. Yeah.
entering
There
branch,
it
yeah.
is.
No, now. Is it okay? No.
Yeah, it is one of the branches.
LAO,
Maybe
Let's
it's
make
RV
let's
branch,
make
no
a
problem.
LAO.
I'll change the wire to a C-on wire now.
Yeah.
No, C-on wire, please.
Just for
This
our
doesn't
our
give support.
demonstration,
if
can
we
you make an
aspirate and if it
injection in
gives
the
blood.
microcatheter? Huh, PK?
No, I will not do that.
You don't do
Because
that. Why?
if, you see
Why?
what happens.
What?
It
Why?
is-
Why?
It is no, I never do that.
Okay,
Because
why?
Why not?
In
Why not?
case I am subintimal,
Did you see blood in the
Oh, in
micro?
case.
in case I
You
am
are-
subintimal,
But you can confirm that with a left injection.
in case I am subintimal, I'll mess up the whole case.
No, but
In
you.
case I am subintimal, I'll mess up the whole case. Otherwise,
When you will be
Otherwise, there's
confirming
no
whether you
problem.
are
I can
subintimal
still-
or intimal.
and how I will check,
Ah.
I will tell you how to confirm. Do
Ah.
a left injection. Come on.
Absolutely,
Yeah.
that's what. Do a left
Do a
injection.
left
Do a left
injection.
injection or check the back bleed of the micro.
Do a left injection.
And even
So
this
I
left
always
injection
confirm it with the
Generally
no,
should be
no,
done
no,
in.
please.
Generally should be done in
There it is.
two
You see,
views
it
so
is
that you are
inside
sure.
the artery,
very
the
well.
microcatheter.
It's good.
Ideally, you
There's
should
no
do
problem.
it in two.
But I will tell you,
right-angle views.
please, I don't want to, the people who want to do this test, I would try to suggest to them, please don't do it.
Okay.
It is not good. Rest is up to you. Okay?
Your point is well taken, sir.
So this is coming out. Balloon trap.
Yeah.
But this was a good case. 6 years old.
2.5
One thing
2.5
in
balloon is
CTO
okay?
is
Yeah,
you
2.5.
2.5 balloon
always,
and
at least when you begin,
koi bhi
whether
de.
now he has a different level of experience, you should always inject in two different views so that you are pretty sure that you are in the right lumen.
Passively.
Yeah,
we
yeah.
see the back bleed.
Actually, I tell you, this is for the Cath Lab people. Biplane systems are very good for CTO operators. Absolutely. If you plan to do CTO and you are having a new setup,
and
look for
structural as
a
well.
and even structural heart. My
Yeah,
friend tells me, yeah, that's
Yeah.
correct.
Because at times you feel
So
you are
biplane
100% in the
setups, I
true
think we
lumen
should
and
look
you are
for more.
actually in the subintimal and then suddenly you realize that you have created a
Especially
mess.
the filter type of wire.
In deflator.
No, actually, the wire field tells you that you are in the true lumen, and the angiogram tells you that you are in the true lumen.
Right.
You don't need to inject, because if you are subintimal, you will mess it up. Try to understand that. You will mess it up.
So we are doing a balloon trap to remove
Yeah.
our microcatheter.
Yeah.
Yeah.
Oh, sorry.
Okay, yeah.
Okay. Trap, please. Trap, trap, trap.
Okay.
Yeah.
This is
Trap.
2.5 balloon trapping.
Yes.
Yes.
D trap, please.
Yeah.
So now we need a dilatation balloon. Let us, do you have an emerge balloon here?
No.
Okay. No, monorail, monorail.
Monorail. No over the wire.
So PK will just shift for some time to the other lab and come back to you. Is that okay with you?
Yeah, certainly, certainly. Yeah.
4 minutes. No, we are with you.
You already done the main
PK,
job.
we are with you for next 4 minutes.
Okay, lie.
Yeah. So
Okay.
we would
okay,
see the.
give me the balloon.
Yeah.
So 1.512. Okay. So here I usually take a smaller balloon and always a New York balloon at this stage for CTOs.
This is a New York hospital.
Oh, this is a New York hospital.
Yeah.
But I am from a old town.
In this city, you'll get only New
You're
York.
from British hospital?
I am from a British
Oxford?
I am from the English
Yeah.
dynasty, you see.
Yeah.
Eh?
So we are the
Lucknow,
American.
Lucknow.
Yeah. So we are
So
the
Lucknow.
American school of thought, and you are the
Yeah,
British
I am
school
the
of
English,
thought. Maybe.
British school of thought.
He's
Yeah.
from UK.
That's a good way.
Maulik,
Yeah.
tell him in this city of Mumbai, only
I'm
NY.
from UK.
Oh yes,
No, so
please.
he is the American guy, I am the British guy.
New York. We are the New York. So I'm from New York, and
Only
he's
New
from
York.
Oxford.
Yeah.
Only New York, please.
Very good going.
But this hospital is fantastic. I
Little
must tell you.
faster.
When I visited this hospital,
Thank you,
this
Giza.
hospital is a 7-star
Bakar.
facility. This
Maulik,
hospital is a 7-star
Maulik,
facility.
Maulik, can you hear me?
Yeah.
Maulik,
Yes, Peter.
what is that
I can hear you,
word? What
Peter.
is that word we were discussing?
What the thing we're discussing, New
Sorry?
York and Oxford.
Come on,
So that's
balloon,
a
please.
code word, sir.
Balloon-
it's very
balloon up,
difficult.
please.
We can't expose that.
Yes.
No explanation.
Yeah, these are code words which are.
Down.
Yeah.
Balloon, please.
But for that
Down.
matter, can I ask my faculty here who are from abroad, is reuse allowed anywhere in
Okay.
your part of the world?
Angio.
No.
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 It's not. Especially, especially
There's a
Maulik,
lesion
I
downstairs.
Yes,
Pardon?
yeah. Let's give NTG and C.
No, I saw
not
that
allowed.
lesion.
Yeah,
You
yeah.
should see the left angio.
I have seen that as well. I
Yes,
agree.
yes. There is a lesion there.
I agree.
So we'll need to dilate that too.
Yeah.
So we can have a 2.5 balloon now.
2.5 compliant balloon, please. Boston, or whatever you have. 15.
Yeah, let us have it 2.5, yeah.
And just to wipe the wire.
Yeah, sure.
Nije short, sure.
Let's take a
12,
12 balloon.
12.
So we'll use the same balloon. Yeah, yeah.
Sada.
Give me a 12 balloon, no problem. 2.5, 12. Because the distal lesion is pretty significant.
You have 2 minutes now. I will come back to you after.
Actually,
10
this went fine.
Yeah,
Otherwise-
yeah.
But I had, because this is a good case, I can tell you, Dr. Kane, this is a good case for ADR also. And that is what
I agree with
call
you,
it
yeah.
salvage ADR. I can at least tell you the theory. Because if I would have gone, because this artery is big, it doesn't have many branches, it doesn't have calcium below, and so this is a good artery to re-enter. So in case you get subintimal, you just, instead of sort of messing it up more, you change that wire, fix the wire there, change it to the.
I think they'll go
Do you have
offline
all
now.
the ADR
ADR
gears
system.
They'll come
in
back
your
to us
lab,
in
sir,
10
right now?
minutes
Huh.
Do you have all the ADR
Yeah,
gears?
I had it. You can.
Yeah, we have
we
it.
have it. Yes, in Lucknow
Yes.
I have it, and I
We have it here
always,
as well.
No, they
here
have
also,
in
yeah.
HN,
I had
HN
only
they have
2
done
sets. You
quite
have
a
5
few
sets.
ADR cases. But KP, I have, this case, when the
Yeah.
occlusion is such a short one, I would not go for an ADR, which is an expensive.
Rather
you can do this,
escalation, wire escalation.
unless you
No,
get stuck.
not
you
a
get stuck.
not a elective ADR.
Yeah,
not a
yeah,
elective
yeah,
ADR.
yeah.
But if you get subintimal, then
Absolutely, yeah. you
instead
can,
of a parallel wire,
Yeah.
you could do a ADR. Balloon, please. Yeah.
If you go subintimal, you can also do Carlino-like technique, putting
No,
a
no,
sen-
obviously
yeah.
you can. Because ADR is
Some
a
kind
little-
of ADR,
little
or
experience.
BAM or
So
something.
basically, when would you, at least I use ADR only if the lesion is very long, diffuse, tortuous.
Sir, now we are switching to our first case from Internal Hospital by
Go ahead,
Dr.
go ahead.
Samin Shamanti.
Yeah, okay. So we are just shifting, we'll
Chalo,
come
koi
back
baat
to you,
nahi, I have
sir.
already
Yeah.
dilated it.
Can you go back to where
Yes,
you
please.
left us?
Yeah.
Is it possible?
Yeah, that's it. That's
I'm going
perfect. Yeah, please go. Okay, are we back live?
Yeah, you're back live
Yeah.
and we want you to
Pressure
go
only
back
12.
to
Yeah, I'm
where you
okay.
left us and quickly tell us what you did.
Okay, okay.
How much
So
time is
can
there
we
for-
show some angios before?
Minus.
Minus.
3 minutes. 3 minutes.
You see,
How
we
much
had
how
crossed
much
the
time is
lesion
there?
and I was through and then
Time
there
is
was
there.
a...
Time is
Sorry. Okay.
So I will show you the IVUS. You see, we had crossed the lesion, you know that.
Yes.
Yes.
So after that, I changed it to a regular wire, to a Sion wire through the microcatheter. Okay? And
Okay.
after that, we did some balloon dilatations, and there was a lesion below. If you, there was a lesion when I have put the stent, there was a discrete lesion below, and the guiding was getting damped at a very proximal point, where again there was disease, and of course my target lesion was about 20 millimeters. So with that, we did an IVUS. Can you show the IVUS? I think it's better you see the IVUS, the withdrawal. So that's where it's come. That's the distal landing zone, so-called sort of okay. But the size here, you see the vessel is at least 3.5 to 4. Now that's the lesion which we dilated. There was a dissection there. This is the in-between segment. Little normal part, but soon we again get disease. Again there is disease, so you know I'll have to cover normal to normal. So I think we need a long stent. That's what I thought. And it's moving a little slowly actually. In the interest of time, you can just go back to the proximal part.
So
Show the
3.5
proximal landing
stand.
bookmark.
If you can, you see that's the CTO segment, and then you have proximal disease.
And the landing zone.
This is the proximal disease, and then we have the proximal landing zone, which is normal, which is pretty big. I would say this is actually 4.55.
So you need two
So
stents or one
what
stent?
we have planned, angio please.
Oh, wait. There's some air.
So do you see any stigmas of CTO on IVUS, or it just like any atherosclerosis?
Oh, sorry.
What was that?
Angio, please. Angio, please. Okay. So I have done the distal stent,
You need two stents.
and that is the CTO part and the proximal lesion at the tip of the guiding catheter. So, my estimate is about
32.
28. 28.
32, 28, whatever, sir.
So you'll have to come right up to the, near close to the
28
ostium,
should
is
be
that right?
okay, I
Yeah.
think. Yeah. Can we have a 28, we can have a 40.
3.5 and we can go up with a 4.
Okay, as you say.
Yeah.
Well,
Because
we can do that.
can be
3.5
four.
going up to.
The
We
rest-
have,
okay.
the
we
rest-
have 1 minute.
3.5,
We
to
can
go.
28.
even do 4 actually. It's
Rest
very
of the
big.
things are usual.
Yeah.
So I asked you
428.
one
Can
question,
we do
Dr. Goel.
428? Is it okay?
Since you are the CTO
3.5
master in our country. do you-
3.5, 28.
Yeah. Can you hear me?
Let
3.5,
Dr.
28.
Maulik decide.
Dr. Goel?
Yeah, please.
Yeah, do you see any
What are-
stigmas
Yes.
of any stigmas of CTO, particular characteristic stigmas of CTO on IVUS, or it is just like
Laker.
any atherosclerosis?
Well, very difficult to say. There is calcium there, some small specks of calcium, but it's not very heavily calcified. And I couldn't see any thrombus type of a thing there. And it was all diffuse plaque and areas of dissection. That's what we thought. If we can show the distal part once
Praveen,
again on the IVUS, if by the
PK,
time we are
PK,
doing
we
this.
might have to leave you in few seconds. So
Yeah.
congratulations for a nice case. Thank you very much.
Yeah,
Okay.
yeah. Thank you.
thank you.
So we
Thank
have,
you.
we have 2 more minutes of the screen time. in
Congratulations to Dr. Maulik and Dr. Whoever is present there, everybody else from HN. Dr. Mashru, I can see Mashru.
Yeah, and the
Congratulations,
team, yeah.
Dr. Mashru. I don't think he can hear us, but you can please convey it to him. He's behind you, PK, Dr.
28.
Mushroom.
Oh.
32
Yes,
would have been
yes.
long.
So thank you very
Yeah.
much for your
Okay.
attention and
Ajay,
for
Mashroor is here,
for
or-
the teams as
Okay,
well. I
okay.
think we
Yeah.
need to hand over the,
Okay, thank you.
the
Test,
chairmanship
please.
and the final position to the other
Test,
teams.
please.
Thank you very much.
Okay.
Test, please, Maulik.
Thank you.